Our next presentation is being given by Dr. Meghan Delaney, and Meghan is spent some time in the Pacific Northwest, but she of late is the chief of the Division of Pathology and Laboratory Medicine and the director of transfusion medicine at Children's National Hospital in Washington, D.C. She's also a professor of pathology and pediatrics at the George Washington University. Meghan and I served together on the board of directors of AABB, and she's also a scientific member of the BEST Collaborative, which you heard a little bit about this morning when Dr. Cardigan was speaking. And she's also a member of the American Board of Pathology Test Development and Advisory Committee. Meghan's research focus is primarily in clinical pathology and laboratory management, transfusion medicine, but she's also got a keen interest in global health, which is what I asked her to come speak to us about today, to focus a bit on safe blood transfusion in developing nations. And so, Meghan, I think that your power's back on and you've got access to internet, so please take it away.
I do. And before I bring up my slides, I finally pulled myself together, and I just want to say to Sharon that was just an amazing story. Telling Cameron's story. So just thank you for that. You know, I work at a big pediatric hospital. I used to work at Seattle Children's, and it was just very, very moving to hear the voice of the mom and what a hero Cameron was. So thank you for sharing that. Okay, so let's hope that my computer works now.
Something's happening. There you go. We've got you.
Are we up? Are we up?
Yep.
Okay. So, so now for something, when Dana asked me to give this talk, this is one of my favorite topics to talk about, and my passion is improving access to safe blood in low and middle income countries. I was really excited to give you a kind of a whirlwind tour. There's no way to cover the depth of the issues in the short time, but I'm just going to tell you a few stories, and then hope that it generates some questions. So first, really just kind of back up and take it in, because when we're talking about blood transfusion, especially in sub-Saharan Africa, which is one of the places I focus, the context of blood transfusion changes. It really becomes an emergency, and because their inventories often are not at all the type of inventory that in North America and Europe we are used to. So the need for blood in low and middle income countries, in particular Africa, bleeding, maternal mortality, most of the women who die of blood loss during delivery are in sub-Saharan Africa. Malaria is also a significant reason for transfusion, particularly for children. And then, of course, traumatic injury, which I heard my friend Dr. Kapp talking about earlier. And there are a huge burden of traumatic accidents that require blood in low and middle income countries. So really the issue that we'll talk about in different ways through this talk is, when there's not enough blood, there's consequences to patients. So these are just a few pictures that I put in real life, which is that's our new thing when we get out of this Zoom world, meaning you can see someone in real life, but these are real life pictures I took. This poster from Ghana, that was actually a recruitment poster. It says the blood bank is bankrupt in terms of, and to enroll as a blood donor, which is an interesting kind of fear generating way to recruit donors. And then both of these refrigerators are in Uganda and Cote d'Ivoire. And they actually look like they have a lot of blood. One of the issues that the blood suppliers can struggle with is access to testing. If the supply chains are not functioning, that the blood might be held actually for a long time before it's released and able to be used for transfusion. So that's sort of the broad scope issues, but I'm going to tell you about three kind of quick stories of some studies that I've done to just describe it in more detail. So first, I'm going to talk about estimating the global need for blood. And so this is a paper that we did, and I'll tell you about as we go deeper, which is a mathematical modeling study to try to estimate the entire world's need for blood. And the model my co-authors on it were really the brain people. I was the transfusion person, but our goal was that we wanted to know how much blood is needed at the national level. And the current way, like the WHO approach, is based on numbers of people that live there, which is not totally incorrect. It's just we thought it could potentially be more precise by actually thinking about, well, what are the transfusible diseases that are prevalent in those countries? So making it more specific for each country individually. So a model was developed where, which is a multi-stage model that first was to estimate the total specific disease, specific transfusion needs as like the gold standard, if you will. And I will apologize, we used the US as the gold standard and knew that that was a flaw in our model from the beginning, but we needed enough data to construct the model. So we said, okay, well, this disease needs this many transfusions. And then to divide the total specific transfusion by the US disease specific prevalence, and we would apply that in different countries. And then to take the lowest, because we were worried about overtransfusion. So to take the lowest, that might be the ideal transfusion rate per diagnosis. And then to use that to multiply it by, well, what is the disease that we're talking about based on the population? And then additionally to now say, okay, well, that's how much transfusions are needed, how much is actually in that country based on supply. So we used a different database for that, and then to calculate the gap in between. So basically this is saying it in a somewhat of an equation, but basically it's a disease-specific prevalence noted to the prevalence of the disease about how much blood you need based on an ideal transfusion rate. So the reference databases are here, which are these HCUP databases. And then the thing that's really the clincher that made this study possible, and Christina Fitzmaurice and Nick Roberts were the real leaders, is from what's called, it's from the IHME, which is in Seattle. It's where it is the group that puts out the global burden of disease assessment, which for those of you that follow that sort of thing, and you might follow it more through COVID, they've been putting out a lot of data around COVID. They're basically health metrics center, they're Bill and Melinda Gates funded. And this global burden of disease is the framework for which we then estimated transfusion needs. Here's the results. So what this shows, I'm going to show a few pictures, all color coded just to get a sort of an overall gestalt of what we found, is that this is the estimated blood need by region and diagnoses. And so you can see like the blues are injuries, digestive diseases, cardiovascular diseases. There's some chronic respiratory diseases. These are very generic kind of codes that come from those types of databases. But you can see it's broken down to all these different parts of the world. And so it just shows you overall, and you might see at the top that parts of Europe actually need the need is very high based on the prevalent diseases that require transfusion, which a lot are digestive and nutritional deficiencies. So this one, it's funny, the zoom is kind of over my slides, is the estimated need for blood, looking at it from a map adjusted for population, which I think is a little easier to look at, but just know that what's feeding this is also those prevalence of diseases underneath. And so what this is showing is the need per 100,000 population, with the red being the greatest need and the green being the lower need. And so you can see that like Canada and the US, like we have pretty high transfusion needs as well. Here we go. So now this is the supply. So I showed you need, now I'm showing you supply. So this is showing the estimated blood supply that we used from a WHO database about reported blood supplies for the whole world. And the green shows per 100,000 the number of units when we just sort of combined all units together. So you can see that the dark green, they have a lot of blood, whereas the red is having less and less blood per 100,000 population. And then the last one, which sort of brings it all together, is this idea of the gap. So the dark green is that the supply matches the demand, and the demand is derived from what diseases are in those countries, are prevalent. The light green is that there might be twice as much demand as there is supply, whereas the red is when there's a lot of demand with supply. So the example is South Sudan has 85 times the need versus the supply. And so this paper has this in all sorts of detail, and you can see every single country in a table. Our conclusions are that transfusion needs really do differ hugely based on the local demography and the disease profiles in the region. And many countries, as I'll talk about as I continue, face critical undersupply of transfusion, which also we predict as cancer care becomes more advanced, or as elective surgery becomes more advanced, actually their need might increase. And there really is this large unmet need for more government support, structural support, and establishment of regulatory oversight to ensure safety in many countries. I'm going to keep going and now take you, so that's really a very high level modeling study, to a much more focused, this is one that Linda Barnes and I have been working on together. This is at the hospital level. And as far as I know, there hasn't really been much assessment of the hospital level transfusion service. And so this one is a much less sophisticated study. It's a survey. And this is a picture of a blood bank in Africa, and you can see that they do have tubes, but they're doing agglutination testing on a tile. So the capabilities at the transfusion service level can be quite different than what we would be used to in North America. So for the survey, we sent out 124 invitations and we got 50 responses across 27 nations. And we divided them by the World Bank classification of their economy. So low, middle, and then middle, upper middle. We actually had it translated into 4 languages, which helped us have that better response rate. But I will still say that I still think that these are somewhat biased in that a lot of them, most of them came from urban areas and teaching. So I still think we are getting transfusion services that are engaged in these questions, and that not engaged, it's hard to reach people. There is no master list of hospital transfusion services for the world. We had to create it ourselves. This is just a picture of those responding countries, just to give you an idea in blue. So, what did we find? So this paper, we're submitting it for publication. And so there's more than what I'm going to tell you about, but focusing on the supply and also, mostly on the supply, that, 77% of these respondents collect blood. They collect blood at the hospital level. And really it breaks down into 3 sections. They either collect all the blood that they would need, or they collect it, or they get it entirely from an external agency, which is the minority, only 23%, whereas 45% get it from a supplier, like a blood supplier, but also have to collect blood themselves. And when we ask them about how they recruit donors, they either just do an open call for donation. Also in low and middle income countries, there's more of a practice called replacement donation, which is if your family member gets a transfusion, then the policy of the hospital is that you need to bring in a donor to replace that. That type of donation model definitely has some pros because it will keep a minimum amount on the shelf, but it really makes it hard for a transfusion service to have enough blood on the shelf for elective surgery, or for big emergency surgeries or big traumas. And they did not report monetary incentives. In terms of when we asked these transfusion services in these 27 countries, what do you transfuse for? The top diagnosis was adult anemia non-malignant. It could be sickle cell disease. And then also adult cancer, and then other elective surgery. But you can see, they're fairly similar in the top reasons for transfusion. So we also said, what is your top challenge? And this one, I think, is probably the biggest finding of this study, is that 57% of the transfusion services that we surveyed said that have experienced or commonly experience not having blood for the patient that was ordered by the doctor for at least 24 hours. So what that looks like is the doctor orders the blood and the patient might be waiting more than 24 hours for blood. And that 57% of these transfusion services reported that. And half of them said this was due to inadequate supplies, and also some said sometimes it's also due to needing specially matched blood. When we tried to figure out, if we did a statistical test to figure out, oh, does that differ on who their supplier is, if their supplier is themselves or their supplier is someone else, is external, it didn't differ on that. They also sort of cited all these other issues that they think are difficult, to makes their working environment difficult. And then one other thing that's very, very dear to my heart is compatibility testing in immunohematology. I'm not aware of this kind of a question being asked to transfusion services in low and middle income countries. So what this shows is, we said, this is a really complicated graph, but just look at the colors. We basically said, do you do gel, tube, slide, or do you not perform cross-matching and antibody screening and antibody identification? And basically what we found is the three sections where I have in boxes across the bottom, is that the low income countries were more likely to use a slide agglutination or a tube, so the lower tech, whereas when you moved up to the upper middle income countries, you can see there's a lot more green, and that means they were using gel. So to us, it shows this direct one-for-one correlation, is that the countries with more resources are using more sort of advanced technology for blood bank compatibility testing. In the places that I've been, a lot of times there is not antibody in sub-Saharan Africa. Many countries do not really do antibody screening. They do cross-match, immediate spin cross-match on a tile. That's as that picture showed. So as I described, this is the most comprehensive survey that we know about for hospital-based transfusion services. That we did really find that many of these hospital transfusion services are collecting blood, even if they're able to get blood from their central supplier, and that blood shortages and the implications for patient safety are many. And there's not a good way to track that. So we think that makes it harder or easier to accept that that's a very common thing. My last little story I'll tell you about is really actually my first experience learning about transfusion in sub-Saharan Africa, and it was part of my practicum when I got my MPH in public health. I went to Ghana, and I just want to tell you about how this was so eye-opening for me, because we think about transfusion and the blood system, but in what context does it live, right? And so in what policy situation, in what financial situation, and in what disease burden situation. So basically, just a word about malaria. Malaria has a global distribution. We talk about the malaria belt in sub-Saharan Africa, and it really does impact small children significantly, with multiple cases, usually during the early years of their life, and that can be fatal. So when I went to Ghana as a public health student, I went there through a connection of my old boss at Puget Sound, now Bloodworks. And he was a med tech who worked at a hospital in Ghana. He was a Ghanaian gentleman, and his hospital that he worked at was from this company, Anglo Gold Ashanti. Well, it turns out that Anglo Gold Ashanti is a gold mine. And the gold mine at a hospital, because it has thousands of workers going down into the gold mine, mining the gold. And so what I learned when I was there was not what I expected to learn. I went to understand how transfusion happened in sub-Saharan Africa, and I took away so much more. So this is some slides from their deck. So essentially, they're a multinational gold mine that operates, as you can see, their dots here, in the malaria belt, right? In a lot of places. And so they were troubled by the fact that the towns that they operated these mines in that were severely impacted by malaria really impacted the health of their workers. And so, these are some data from their 2005 analysis, and that over 2,500 of the many, many thousands of people who got malaria that year at their hospital, they were mine employees. They had to take time off. They had to pay for their medicine. During recuperation, they were not feeling so hot, so they weren't so efficient. And then in the community, the people who were working in the mine, their families were also sick. So what they did is they put in this just spectacular malaria control program, which consisted of essentially controlling the vector, studying the vector, and distributing all sorts of public health teaching and bed nets and all sorts of things to try to prevent malaria in the whole community, not just the mine workers. And so these are just some pictures. I visited this location, and actually they were growing mosquitoes and testing them with they wanted to make sure that they didn't become resistant to the pesticides. And the gentlemen in blue suits that are spraying, that's called, they do it inside and outside. They would come to the houses and they would put all the furniture in the middle and they'd cover it up, and then they'd spray all the walls. And then the outside of the house, they would write a number or a date. And then they would cycle that pesticide to keep the mosquitoes down. And so how does this have to do with transfusion? Well, remember, I said I also very much focused on pediatric transfusion. So Daniel and I dove through the hospital's registry, which was handwritten records from 2003 and 2009. And what we looked at was the 2003 was before the malaria control program was in effect in the town, and 2009 was after. And so the black bars are 2003 and the white bars are 2009. And so the first set on the left-hand side is patients tested for malaria, and then if they were positive. So you can see that MP positive is malaria parasite positive. So we had a drastic decrease of the number of just overall patients that were tested. And then we looked at children in particular, and if they were positive, so that's where the two red lines with malaria positive. And you can see the drastic drop of children who are now getting malaria because they're treating for mosquitoes to take care of the mine. And then the last one was malaria positive children that needed transfusion. And that also significantly dropped. So we published this in Vox Sanguinis in 2010. And to me, I like to tell this story because it stitches together corporate beneficence, finances, everything about public health to show how complicated it all is. And honestly, this blood bank actually had a pretty good donor base. They had great connections with their church, but they were collecting blood at the hospital level. So that's my whirlwind with my 3 stories about global transfusion. And, I think that the bottom line is that the world does not have enough blood where it is needed. And certain prevalent diagnoses do increase demand. That especially in the low and middle income countries, hospitals often collect and test blood themselves due to either a lack of external suppliers or also in a replacement donation model. And that hospitals also do not have all the resources they need to perform pre-transfusion testing. It doesn't, I also don't want you to take it as a demoralizing message. There's a lot of great people working on this. There's been some incredible science around when to transfuse children with severe anemia that just came out in the past few years. And so I do think over time, this topic of transfusion, especially in low resource areas, has become more of a focus point. And all of these folks here, I just wanted to thank their people who worked with me on all these projects I just presented to you. So thank you very much for the time, and I'd be happy to take some questions.
Thank you very much, Megan. So Megan's ready for questions. I see Dr. Conway's got his hand up. Got to take yourself off mute.
Okay, I just got permission. I got to get on a view so I can see myself and you.
I can stop sharing.
Maybe, yeah, maybe.
Yeah, there you go.
There we go.
Okay. Okay. Megan, that was fantastic. It's really interesting. I'm personally interested because I spend a fair bit of time in Uganda, and where my wife works a lot, so I can really understand. What I'm curious about is that this huge project, which is really interesting, and where does it lead? I mean, you who I could have told you the results of these studies, right? And anybody who's worked there and got their eyes open, and I'm not criticizing, but I'm just pointing out, you've done, it's cost a lot, you've done a lot of work, you've characterized the deficiencies, which are intuitive. I mean, it doesn't take anybody to go to visit these countries and see they're desperately needing. They don't have the infrastructure, they don't have the knowledge. It's highly localized in terms of the challenges, whether it be malaria, HIV, tuberculosis, the poverty, all the inequities. How do you tackle such a problem? Meghan, solve the problem.
Yeah. I mean, when I'm listening to you, Ed, so, the question is, why do I do, to me, it's to raise awareness that the big modeling study. So Christina Fitzmaurice, I was her mentor that was her K-12 scholarship project. And it was such a good idea. And it did raise awareness. I think what I am constantly struck by working as my day job is, to run a hospital in a very high level of complexity in a wealthy country, is that actually a lot of people don't get to go. And they don't get to see it for themselves. And it is life-changing to see that stark difference. So I feel like, if anything, if I can just communicate it and make people know that it's happening, how to fix it all. That's why I tell the story of that Ghana, my experience. I went there years ago and it was very naive. I'm sure I'm still naive, but it was so eye-opening, because I also, I guess politics, I'll say, I don't really like the idea of mining. I'm more of a green progressive. And I was like, what, a mine? And then I got there and I'm like, wow, they have done so much good. They have prevented so much death. So about that complexity. And I think also there's this colonialism that the wealthier countries have, and we have to prevent ourselves from doing that, because then we put in non-sustainable solutions. So I don't know the answer, but I think we have to just, like those of us who have passion for it, keep talking about it, because I do think it's worthwhile. But thank you for your comments.
Thanks, Ed.